All right, so here we are in week two, gearing up for exam one. Um, so if you have not, if you have not attended any of the reviews, I think there is one more. Let me just double check before I say that. Um, do. Yep, there is one on Friday at 4:30. That will be the last live review. And then of course, as they are coming in, I've posted my recording, and Dr. Tenz's recording is there as well. So the next one will be Miss Foster. And again, hers is Friday at 4:30. And then, of course, as soon as her review is done, I will post that recording as well so that you have it. Oops. All right, so I had a question. No, so for one, and the exam reviews are not mandatory. They are just highly recommended. Only the sorry, hold on one second. So the one really good thing about the live reviews versus the recordings, right, is that you can ask questions if you have questions or don't understand a topic. If you can't attend the live reviews, that's why we post um, the recordings so that you can go back and review the recordings. If you need any clarification on topics, so let's say you only get to review the recordings and you don't get to go to a live, a live review. If you need any clarification, please feel free to reach out to me, um, call, text, email, so that we can clarify any of the information that is oh, okay. I'm trying to answer questions. So to answer the question, if the exams will be med surg questions and law and ethics. So the topics on the exam are going to be related to this course. Okay, so there may be some med surg type questions in there, but it will be specifically related to the information that you were covered in weeks one and now week two. Um, and then I'm gonna answer this one. Um, mm, okay. All right. I just wanted to make sure I got did I answer everybody's questions? Just want to make sure. Because there are a couple out there. I just want to make sure I answer your questions. So, like I said, they're not mandatory and we know schedules are crazy. So basically just I'm gonna leave it at that. But if you can attend a live review, it is beneficial if you attend a live review. Um, so for today, today's topics are ethics and nursing and the law. Um, so this is chapters 6 and 7 in your I always forget the name of this book in the Success in Practical Vocational Nursing book. Um, so just give me an idea. What is ethics? Tell me what ethics are. What is ethics?
Is a
Uh,
system of standards or moral principles that direct actions as being right or wrong. Ethics is concerned with the ways people either individually or as a group decide the following: what actions are right or wrong, if one has the right to do something, if one has the duty to do something.
Awesome. Thank you. Very good, Latoya. Janika, can you turn your camera on, please? Thank
I'm
you.
sorry, I thought it was on.
It's okay. So yes, and let me share my screen. I always forget that part. All right, so here we go. So absolutely. Okay, ethics is a system of standards um, or moral principles, sorry, that direct actions as being right or wrong. And it's concerned with the way people, either individually or as a group, decide what actions are right or wrong, if one has the right to do something, if one has the duty to do something. And so, looking at all that, those are really kind of just, it's really just like a nice little basic definition of ethics. It is different than morals. Okay. So morals are different from ethics, although sometimes that we tend to kind of put them together. But morals themselves are just dealing with right or wrong behaviors or conduct as well as your character. So look at personal versus professional ethics. Okay. And this is something, we don't often think about it, right? So personal ethics are your personal guidelines for living. Okay. So you choose, right? You choose what your personal code of ethics is, right? What you think is right or wrong. Um, and that your personal code of ethics also is going to influence your nursing ethics. And like it says here, sometimes personal ethics conflict with the law, and our law regarding nursing is always going to be our State Nurse Practice Act. So if there is any conflict between your personal ethics versus professional ethics, you have an obligation to follow the law. So what do you think? Okay, give me an example of what you think where there would be a conflict between your personal ethics and your professional ethics.
DNR or DNRCC or not to or full code.
Okay, okay. What about caring for somebody that has an alternative lifestyle that you disagree with? Or, and we could go real deep with this, but what if it's, let's say you're working in the emergency room and you have a patient comes in who had a botched abortion and you don't believe in abortion, right? It is still our obligation, right, to care for that client. There's so many potential examples here. Another one that I often think about too, especially in our time and age, and the way society is. Um, what if you're working in the emergency room and let's say the, ambulance brings in um, someone who had just committed a mass shooting and they were injured and now they are in your emergency room and need treatment, right? And you already know what happened, right? So, right, there's a lot of times where our personal ethics and our professional ethics can conflict. And I always say, one of, our job as nurses, right, is always to care for the patients, regardless of what they've done. They are still humans, and we take that oath, right, to care for people. And I'll share an example from my nursing background. Um, we actually had a patient who had murdered his family, his wife and kids, and then burnt his house down to try to cover it up. in the process. And it's just kind of, one of those karma type stories in the process of like waiting for trial and, the whole, he was out on bond and he had a stroke and was deemed mentally incompetent. And so he literally was, required 100% total nursing care. So, we all, we knew what he had done. It had been all over the news, right? And so we still had to care for him, right? He is a human being, regardless of what his actions were. And so these, like I said, there's going to be situations at some point, and I mean, it doesn't have to be and related to any of those. It could be even, I always go for the high profile ones, right? Because it really stops and it makes you think, right? What would I do in that situation if that were to occur? But always remember that our goal is to treat everybody as a human, and we take that nursing oath, and our job is to care for them just as we would any other human. And I always look at it this way, and this, but if you are in the emergency room and that shooter comes in, right? I want to provide the best care for him, right? Because you want him to get better so he can go to trial, right? So there's always, you can always look at it that way too. Other things may not be as cut and dry or as black and white. There's always gray area, but we always try to do the best, right? Provide quality care regardless of the patients that we are caring for. In a situation though, let's say there's just absolutely no way that you feel that you can care for that patient. What should you do? What would you do?
Could you go to your supervisor, and let them know how do you feel about this case or whatever patient that you have?
You can. You can go to your supervisor, you can go to another nurse and just kind of tell them what is going on. Doesn't necessarily mean that they're going to take that patient, right? In some cases, they can, if another nurse is willing to pick up that patient, depending, of course, on what's going on, you do have that right to do that if it is a strong ethical, conflict where you really feel that you cannot provide that appropriate care. Like I said, doesn't necessarily mean it's going to happen. You still may have to take care of that patient, but that is an option that you have. Oops. Let's see. I'm going to just correct my spelling real quick here. Um, when we look at individual autonomy and rights, okay, so we know every patient, every person has rights, right? When you walk into a hospital or you walk into even even sometimes, in doctor's offices, there is a Bill of Rights, right? Patients have a Bill of Rights. And so, and just as being human, right, we have rights. So, individual autonomy. What is autonomy? What does autonomy mean? What does it mean to be autonomous?
Free to choose.
It's your freedom to choose, right? Your freedom to make your own personal decisions. So, individual autonomy means self-rule, right? We have the capacity to think, and then based on those thoughts, we make the decision freely whether or not to seek healthcare. And of course, this is nursing, so we're going to talk about healthcare. Um, and so, with that being said, right, if something happens, if you don't feel good, you think you have the flu, right, you're the one that ultimately decides, do I want to go to the doctor or do I not want to go to the doctor? Or, am I going to wait a few days, see if I feel better? Individual rights is your ability to, or yeah, individual rights is the ability to assert your rights, right? And so a lot of times, right, the ability for us to extend to, exert our rights is restricted, right? So just think of societal rules and regulations and laws. right? We can't infringe upon another person's rights. So that's the only real restriction as long as we're doing what is good for us. But so, for example, the client's right to refuse treatment can be at odds with the health professional's perceived duty to always act in a way that will benefit the client, right? So let's say that we have a client who somebody said DNR earlier. But let's say we have a client who is, you know, diagnosed with cancer. They're young, they're previously healthy, and the doctor, the provider is recommending chemotherapy, radiation, and they decline, right? That, is definitely going to go against the providers, right, to act in a way that'll benefit the client because here you're young, you're otherwise healthy, you have this new diagnosis. We can treat you with chemotherapy and radiation, but you're refusing, right? So, that could be another issue. But we have a right, and I say we because we're often patients ourselves, right? We're not just healthcare providers. We get sick, we have things happen to us. But individuals' right has become a central theme in healthcare. So they have the right to consent to care. They have the right to choose between alternative treatments. They have the right to consent or refuse treatment. And then even women's rights over their own bodies. So there's lots of, there's lots of thoughts about all of this. But we generally, as a humans, we have the right to make decisions for ourselves, what treatments we want, what treatments we don't want. And, in some cases, if you guys are parents, right, we often have to make those decisions for our children as well, right? What's the best options for them? So with all of that, we have, of course, our ethical responsibilities. So what does it mean to be an advocate? What does it mean to advocate for somebody?
Talk for them.
Okay, talk for them, right? So, we as nurses, we're going to meet people on some of the worst days of our lives. Sometimes we meet them on some of the best days of their lives, right? If you have a brand new mom coming in labor and she's all excited about having her first child, right? Hopefully that's a good day for her. But regardless, whether it's a happy or if it's not such a good day, um, they're still vulnerable, right? They're in a new environment, not really sure about what's going on. And, being in the healthcare system, lots of people coming and going, lots of things happening, could be overwhelming, especially if they're sick, they're injured, they've had a trauma, right? All these people coming at you from different directions can be very overwhelming. So one of the biggest things that we do as nurses is, we do need to advocate for them, of course. But one of the best things and one of the biggest things that we can do as nurses is give them information, right? Knowledge is power. We all know that, right? The more you know, I always think of those commercials. I don't know if anybody's ever seen them. The more you know commercials, right? So making sure that the clients are informed about the plan of care that they are going to be receiving. Even if you're going to go in and you're going to do a procedure, tell them what you're doing, what is happening to them. Um, I know, like even when you're out in clinicals, right? If you're doing a procedure, inserting a Foley catheter, even if you're going in just to talk to the patient or reposition them or do something, right? We always tell them what we're doing, no matter what. I remember this one time, a long time ago. This is when I first started in education. I had a group of nursing students. I think they were in their second, so the courses ran a little bit different. But they were in their second clinical course and um, this lady needed to have a Foley catheter placed. And so I sat, of course, I always ask for volunteers. So this one student raised her hand and she was like, I want to do it. I want to do it. I'm like, okay. So it was so funny. And I was like, looked at her. And so we went through the whole procedure, like how are you going to do it? You're going to, we went from the beginning, like you're going to knock on the door, you're going to introduce yourself, right? You're going to tell the patient what you're going to do. And then, you can just talk through the procedure as you're doing it. And we walked in the room and she knocked on the door and she walked in the room and she completely froze. I was like, tell her what your name is. Like I was like, um, but she started to just do the process and I had to stop her and I was like, sometimes in situations, right, we freeze, we don't really know what to say. And a Foley catheter, of course, is an invasive procedure. Um, Always think, if you were laying in that hospital bed or you were sitting in a hospital, what would you want to know? How would you want to be treated? What are things that we would make you feel better? And so always telling them what is going on. And so, always just looking, and making sure that we are doing what is best for the client. But knowledge and education is going to be right up there, always making sure that we aren't violating their rights, that they know exactly what is going on. Always, if you're unsure, you always can go to the RN and, consult with the RN and see what other things that you can do. What is accountability?
It's taking responsibility for your own wrongdoing.
Okay. Not always wrongdoings, but it's taking responsibility for your actions, right? So you're responsible, you're answerable to yourself, to your patients, to your coworkers, to your boss, everybody, then you are responsible for all of those nursing actions that you perform, okay, or that you are assigned to perform. And when we look at how do we measure accountability, well, that's measured by standards of practice. Okay, what are the standards of practice? And are we living up to those standards of practice? And so, standards of practice, standards of care, those are things that a prudent nurse with your education and your experience would do in a similar situation. This one, unfortunately, it happens. And I always say that I hope it never happens to you. I hope you never have to be put in this situation. But colleague reporting. So if a peer, a supervisor, any other of your team members are, have or exhibiting any behaviors that could potentially harm our patients. So, are they impaired? Are they are they drunk? Are they drinking at work? Are they taking medications? Are they, diverting patient medications for their personal use? Sleeping on duty, verbal, physical abuse. These need to be stopped and reported immediately. Um, and I actually was reading a case um, that a nurse was physically abusing a client in a long-term care setting. And another, I don't remember if it was another nurse or if it was somebody else that had witnessed the abuse, did not report it. And so when the nurse that was actually performing the abuse got caught, um, and during the investigation, it was found that the other nurse, or I can remember, like I said, I don't remember if it was a nurse or a CNA, had witnessed the abuse and did not stop it and did not report it. And she was held just as responsible as the nurse that was actually performing the abuse. Don't ever cover it up. Even if you think it may be an isolated incident, you do not know that. So it is your responsibility if you do see it, witness it, or even, hear about it. It's always better to report it and let them do an investigation. System-based issues. So this is another thing too. So system, and looking at identifying system-based issues is it's also essential to providing, of course, that high quality, safe care to our clients. So healthcare is ever changing, new procedures, new equipment often are implemented. Sometimes not everybody gets the appropriate education or the appropriate training on the new procedures or the new equipment. And I always say night shift gets the short end of the stick sometimes, especially with that. Um, if you have not been trained on a new piece of equipment, do not use that because you don't want to use it and have something happen where it's unsafe. And so you always want to notify whether it's administration, your supervisor, that you have not had the training on that equipment, and then, suggest the plan to make sure that, we are providing for safe care for our clients. I always say, if you recognize a problem, it's always good to point out that there is a problem or an issue, but offer a solution at the same time. Like sometimes, supervisors, managers, they don't always recognize certain things. But if you come to them with a problem, offer a solution. And then that gives them something to think about. And it also brings it to their attention that there is a gap. These I'm sure you've heard somewhere along your nursing program. And so our wonderful principles of ethics. And so again, this is, the basic foundation of what we do as nurses. The first one is non-maleficence, which means to do no harm. All right. And so we look at why we do the things that we, do, especially, in nursing school. But, why do we teach you the rights of medication administration and the three checks? We teach you about proper handoff and proper communication like SBAR. Um, and there's always the bed in the lowest position, side rails are up, fluids within reach, right? All of the traditional. But that is right. There's reasonings behind why we do all that. Majority of it's patient safety, right? If I follow the rights of medication administration and I do my three checks, right, that helps to ensure that I'm giving the correct medication to the correct patient at the right time, et cetera, right? SBAR, right? The use of SBAR is an effective communication tool. It ensures too that you're providing all that pertinent information, whether it's to a doctor, to a coworker, to shift, when you're doing shift change, putting the bed in the lowest position, raising the side rails, right? That helps to prevent and provide for safe care. So we have to look at that, right? Because if we don't provide safe care, that increases the risk for falls and injuries. So our goal is to protect our clients, providing that safe care. The second one is beneficence, which means to do good. And I know sometimes this sounds very similar, right, to non-maleficence. But do good with your nursing actions. Okay. Doing good is the basis of trust in nursing, right? It also involves preventing harm and removing harm. And so this is, putting your client first. So you don't leave at the end of your shift without making sure that you give report to the oncoming shift, right? You want to make sure that you tell oncoming shift all the pertinent information that they need. If you make an error, it's reporting that error and assessing your client for any potential harm to your clients. So again, it's just putting your client's needs above your own. That can also include your advocacy, right? Always trying to make sure that we are giving them as much information as possible for them to make that decision. Autonomy, we talked a little bit about it. Autonomy is the freedom of choice. Okay, so that's, we're respecting their independence, their right to determine a course of action. It also includes privacy as well. But autonomy is, you're given some information, like let's say, I don't know, let's say someone fell and they broke their arm. Okay. And the doctor is going to come in and say, here's the options. Okay. We can, put a splint, we can do a cast, we can do surgery. I don't know, just throwing stuff out there, but these are the options for care. These are the potential adverse effects, the potential complications, but here are the benefits to each one. So as a person and my freedom of choice, I can think through all of that information that the provider gave me, and I can decide and act based on, the information and what I feel is the best decision for myself. Okay. And this needs to be made without any pressure from anybody else. Nobody should be pushing them one way or pushing them another. They should be just given the facts and being able to make that decision. When we look at the role of privacy in autonomy, privacy is both a legal and ethical issue. Okay. And again, autonomy does include their right for privacy. And so I think the book says it's just like when I was telling you the story about the nursing student to insert the Foley catheter. Now, as as a nursing instructor and the experienced person of, one of the things that I would go and do is ask that patient, hey, I have some student nurses, right? And they would like to perform this procedure. I will be in the room with them. They won't be here by themselves, right? But that is something that could, potential, that's also, part of that privacy. But privacy is something that, it's continues on with their right to choose care. So we always think of it as important. What are some other things that would fall under privacy in this situation? Like with just privacy, what do you think would be some other potential issues?
Not discussing their name in a open setting.
Okay. What about trying to think of a good one. I can't think of another. I can't think of a good one, but that was a good one. That was a good one. Um, Fidelity. What does it mean? What does fidelity mean? I mean, it says to be true, but what does that mean? What does it mean to be true?
Like loyal in a relationship or not loyal if it's infidelity.
Okay. Loyalty. That's a really
To
good
be
one.
honest,
I'm sorry.
to be honest,
Be honest, right? Be loyal, be honest, be faithful, right? Um, Always acting in the client or the patient's best interest, especially when the ability for them to make choices isn't available. Okay. So it doesn't always mean that they're incompetent. So think of this. So, and I know you guys have heard this too before. Um, it's not talking about patients in the hallway where other people can hear. It's not, going to lunch and sitting in the cafeteria and discussing patient care in a wide open area, right? It's not, even in the elevators or things like that. And I know sometimes it seems like, oh, well, I didn't say their name. I was just talking about their behaviors, or I was just talking about their diagnosis. You never know who is listening. And I will tell you from experience, behavior sometimes can be recognized by family members. Oh, that's exactly what my dad would do or my mom would do. Um, and so, and I had this happen personally. So my mom was in the hospital and so my mom had something called sarcoidosis, okay? And she was in the hospital. And periodically she had the sarcoidosis was in her lungs. And so periodically she would get become more inflamed than normal. And that drew up, obviously it's going to mess up her CO2. And when it would get like that, she'd get a little loopy. And we just knew that it was time for her to go to the hospital. And so long story short, um, we had some nursing students, and of course they didn't know that that was my mom. We didn't have the same last name. Um, and they were just talking about her, and they weren't, I will say they weren't like being mean or anything like that, but they're like, she was crazy. She was this and she was that. And I was just listening and I'm like, and then they said something, and I was like, I'm gonna need you guys to stop. And they like looked at me, but well, we're not talking about names or anything like that. I said, I can tell you her name. And they looked at me and they're like, well, how do you know you weren't there? And I was like, because you're talking about my mom. Like I just flat out went. And they are like mouths all dropped. Um, and they just looked at me and I was like, would you like me to tell you her name? And and I said, because I'll give it to you. I can give you her birthday. I can give you her social security number. I was like, we don't talk about patients. And they, like I said, they weren't being negative, but you just never know. You never know when you're in that situation. Um, and just being careful. And I was grateful that they didn't say anything negative because trust me, with my mom, they probably really could have. Because when she got that like that, sometimes it was, she was a little bit more difficult to deal with. But we always have to be true to our patients. And even if and that's one of the things, if you hear other nurses, if you hear, um, even support staff talking negative about a client or a patient, right? It is our job to stick up for our patients. We don't know our patients for the most part. Um, yeah, that is true. Thank you. We don't know what people were like before they came to the hospital, right? Their behaviors, who knows, some of their behaviors may be normal, some of them may be abnormal. But we always try to make sure that we are doing the best, right, for our clients. And talking bad about them, right, that may not be their normal behavior. You don't know what's always going on with those clients, so being respectful of that. Um and just the fact that people are sick and in the hospital, that can make people a little on edge, right? I mean, I don't know if anybody's spent any time in a hospital, but it can be very overwhelming, right? There's lots of noises, lots of people coming, going, and it can be very, like I said, it can be overwhelming, it can be overstimulating. And especially think about our older population, right? Our older population, all that stimulation can cause delirium, right? And other issues. And justice, it just means being fair. So you're delivering fair, equal treatments to all of your clients, and this is kind of what we were talking about earlier, right? Recognizing, personal bias, that conflict between professional and personal ethics. We try to put those aside, provide the same care for our clients. You just treat them as, treat everybody with dignity, with respect, with empathy, with caring. Anybody who work in long-term care or have any experience in long-term care? Nobody has? Oh, yes, we have got a couple. What about what about your two old lady roommates? What you do for one, you better do for the other, or you're never going to hear the end of it, right? Um, and I'm not saying that, it has to be like that all the time. But just be respectful, making sure that you're treating everybody appropriately. Um, just I always think of that. I can't tell you. I don't know what it is about little old ladies, but if you don't give them the same attention, especially if they're roommates, they get very insecure and upset. You don't like me, you like her more, and it can just start a whole downward spiral. Um, then we have this also falls kind of in your ethics, it falls under ethics as well. So this is a term, it's called beneficent paternalism, okay? And just the general, overview is a very disrespectful attitude towards clients, and what they contribute to their personal care as well as their recovery. It's an I know what's best for you attitude. So it discounts the client. And so I was always trying to think, this could be something as simple as not including your client in writing the care plan, or, and especially with those interventions and goals, right? We need to include them. They have to agree to that plan of care. The other, another situation where this would be is if a client asks you, what would you do if you were me? Because people will ask you, well, what do you think, what would you do if you were in this situation? Well, best thing that you can do is, say, this is not my decision to make. This is, your personal decision. We can provide you with all the information that you need in order to make that decision. If you said something like, if I were you, this is what I would do, that could be an example of, beneficent paternalism. Now, with that being said, it is only justified in extreme circumstances and is usually related to a medical decision, um, for a provider to do a potentially life-saving procedures, usually in children, if the parents are refusing to sign authorized treatment. So, I'm just going to use the example of a Jehovah's Witness, okay? Because we know Jehovah Witnesses, right? They don't accept blood products. Well, what if we had a child that had had a trauma and they come into the emergency room and they absolutely need blood products, and the parents say no? The healthcare provider, the facility can petition to the courts to get a court order, in order to have that child receive a blood transfusion. Okay. I don't know. This was also, I'm trying to think if this was many years ago, a long time ago. And I don't remember the exact year, and I don't remember the whole, like all the ins and outs of it. But there was a child, that had cancer. And the parents had opted not to use traditional medicine. They were going with more of the non-traditional therapies, the home remedies, in order to treat the child's cancer. And so I forget what hospital it was, had gone and petitioned the court in order for the child to receive their cancer treatment, because the cancer initially was very treatable. And some of the therapies that the family were using, while they may have been beneficial for the child's health, um, it wasn't doing anything to slow the cancer growth. So they did petition for them to go, and have the child receive treatment. So again, not generally a good practice unless it is, something like a child and the parents are refusing to sign treatment so that they can petition the courts for an order. All right. So, more about law and ethics. What is the Nurse Practice Act? What is the Nurse Practice Act?
Is it standards for nurses in your state?
Yes, it is your rule book. Um, your each state has its own Nurse Practice Act. Okay, so every state, doesn't matter what state you're in. If you're in Florida, you have one. If you're in Ohio, you have one. If you're in Pennsylvania, you have one. In Hawaii, in Alaska, New York, every state has a Nurse Practice Act. Okay, and that Nurse Practice Act is what establishes the standards for your practice in your state. So it tells you what you can do and what you cannot do as an LPN, as an RN. It is absolutely imperative, if you have not already, look at your state Nurse Practice Act and know exactly what is within your scope of practice before you start to practice nursing in your state. Now, with that being said, I'm going to say that with the compact licenses or the multi-state licensure, okay? So the multi-state licensure does say that you can practice right in another state under your, as long as they are a compact state and you have a multi-state license that you can practice within that state. Um, you know, um, so one thing to know there is, let's say, I mean, I know some of y'all are in Ohio, okay? So, um, if maybe you live in Ohio, but you're close to the Pennsylvania border and it's closer for you to work in Pennsylvania than it is, to find a hospital in Ohio. Okay, it's going to be your responsibility to know what the Pennsylvania Nurse Practice Act is. Okay, if you're living in Florida, I don't know Florida too well, but let's say you decide that you want to practice in Georgia or Alabama, okay, or somewhere, right? I think that's Georgia, Alabama, right? I think I got the states right. So you would have to know what that Nurse Practice Act is in that state, whether it's Georgia or Alabama. You would have to know that Nurse Practice Act. Similarities are, then there are lots of similarities across, especially with the multi-state licenses or the multi-state compacts, because, right, we allow you to cross into another state in order to work. But again, I'm going to tell you, it is your responsibility to know your Nurse Practice Act. So with that being said, the Nurse Practice Act. All right. So some of the content of the Nurse Practice Act. Okay. So the Nurse Practice Act, again, it is the rules and regulations. And it includes the general provisions. So under general provisions, it's, it'll talk about what the functions of the state boards of nursing is, general procedures like fees, the licensure process, elephant, what would be considered unprofessional conduct, any information related to reasons for a suspended or revoked license. It also will also include information regarding the Impaired Professionals Program. The responsibilities, it defines the general functions of the licensed nurse. Okay, so it's going to, what an LPN, LVN can do, what an RN can do. It also defines nursing practice. Okay, so there are specific definitions for LPNs, LVNs, and professional nurses. It also will outline the standards of nursing conduct. And then other things, organization, approval, administration of nursing programs, as well as continuing education. So with that, we're going to a little bit more about the Board of Nursings. So the functions of the boards. So state boards of nursing, they can have either a single Nurse Practice Act or they may have two. It really just depends. So you may have one Nurse Practice Act that's all inclusive, or you may have two, one specifically for LPNs, LVNs, and then one for the professional nurses or the RNs. But it is going to define what your scope of practice is. Other things, licensing and certifying. Okay. Licensing. So, when you graduate, in order to go sit for your state boards, you're going to have to apply for a nursing license through your state board of nursing, as well as register to take your NCLEX. So they're the ones that are going to issue your license, once you pass your NCLEX. They will set the fees. How much is it for an initial license? How much is it for a renewal? How much is it if I forgot to renew and now I'm late? What do I need to do? It also establishes the standards for educational programs, and you can go to any of the Board of Nursing websites. All of this information is open to the public. There's nothing hidden. You can see exactly all of this information. Establishing standards for educational programs. So making sure that, whatever the requirements are from that state's Board of Nursing, if there's a nursing school that is or even a CNA program that is operating within that state, that the school is adhering to the guidelines set forth by the Board of Nursing. So, and there's a lot, I know from experience, but I also used to hear, well, how come we have to do so many clinical hours? That was always one of the big questions because the Board of Nursing said so. So in the provisions for educational programs, it tells you, look, students need to do this many clinical hours. It also approves the schools of nursing. So, I can't just decide, hey, I'm going to open a school of nursing just for fun. You have to go, there's a whole approval process that needs to be done. They review the curriculum, they review the site, the equipment, the administrative policies, and they look at everything. They determine the duration and the renewal of licenses. Okay. So do you have to renew? Let's just say like in Virginia, I know I always wondered why, and still don't understand it, but like CNAs, they had to renew every year. I don't know if it's like that in every state, but your CNA certifications, they had to renew every year. Wasn't horribly expensive, but still, that's something to remember. Every year you gotta renew. I know that for nurses, it was every 2 years. And I know here in Texas, it's every 2 years to renew. But they're the ones that will tell you how often you have to renew your license and how much it's going to cost. I should move to Texas because it's a lot cheaper to renew your license down here. I was like, wait, how much? I was really excited about that. Continuing education. So this is another reason why you should look too. Do you need to have continuing education credits in order to renew your license? And so that is something that you have to look to see how many hours of CEUs that you need to have to renew your license. When you do your workplace stuff. So, I want just for clarification, CEUs are different from in-services. Okay. So I know a lot of times, especially in healthcare, when you're working for an organization, you have a ton of in services that you need to do, whether they're computer based or in person. Not all of those have CEUs. So you will have to go and find CEUs. And it's different for each state. I can't remember how many I have to do. I've already done them, but you have to do them yearly. So it's not get your license and then you're 2 years from now, you're like, oh my gosh, I have to renew my license. Let me do my CEUs. If you get audited, they're going to want to see that you've done them over the course of 2 years, not just the night before you're getting ready to renew your license. They'll also maintain your inactive status list. They'll also carry out disciplinary action for violators of the Nurse Practice Act. They also develop programs for impaired nurses, and those are your nurses that are maybe have some sort of a substance abuse, whether it's alcohol, drug diversion, that kind of thing. they have programs through the boards of nursing. And I will tell you, I sat in before I left Virginia, I sat in on one of the meetings, and I thought it was really interesting that it was very, very expensive for these nurses to go through the program, but that helps them to keep their nurse's license. So it's, kind of what you have to do. Um, they also, of course, can suspend, revoke licenses, dealing with any of the appeals process that might occur as well. So each state's Nurse Practice Act is going to list specific reasons why they may seek to discipline a nurse for unprofessional conduct. And so language obviously is going to be different from state to state. But these are some of the things that would potentially be considered unprofessional conduct. Negligence. So negligence is not doing what a reasonable, prudent nurse would do in a similar situation. So this is usually serious risk to the health, safety, physical or mental health of the client. Any violation of your Nurse Practice Act. That's why I said if you haven't looked at your Nurse Practice Act, look at your Nurse Practice Act. Some states' Nurse Practice Acts will list specific violations. Such as like becoming personally involved with a client. I actually read that. I read one where not long ago there was a nurse that started an intimate relationship with an inmate at the prison that she was working with at, and she had her license. I don't remember. I think it was her license at the time was suspended. Incompetence. This is a big one. So this is like examples of this: failure to meet generally accepted standards of nursing practice, negligence, or even sometimes a nurse's mental disability that would interfere with client safety. Unethical conduct. So breach of nurse client confidentiality, refusal to provide nursing care for someone based off of creed, color, race, national origin, disease, or sexual orientation. Talked about that a little bit, right? And violation of the ethical code for LP and LVNs and failure to maintain nursing competence. Okay. It is up to you to maintain your competence in your skills. It is up to you to make sure that you are current in your practice. And then, of course, alcohol and other drug abuse. Alcohol and other drug abuse by a nurse is a threat to client safety. So some nurses steal and sell diverted drugs and equipment such as syringes, IV tubing, and then falsify those clients' records, which means that the client isn't getting their medication. Oh, they, so this is a really good question, and I'm going to read it out loud. It says, could they use a nurse that is seeking mental health therapy against them? It depends. It depends. If it puts client safety at risk, then yes, I have seen it. But it's not like, it's not, it's more of, how do I explain it? I would have to actually find an example. Um, Depends on what the treatment is. Like, let's say you have a lot of people suffer from depression, right? A lot of people are on antidepressants, okay? If you're seeking therapy for depression and you don't have any other, and I hate to say this, but I guess the best way to say, if you don't have any other issues, okay? Like you're not suicidal, you're not homicidal, you're not doing anything like that, your behavior is not erratic, then no, they really are not going to use that against you. It is only when you put your patients at harm or put them in risk's way that they could potentially use that against you, if that makes sense. As long as you're providing safe, effective care for your clients, then you're not. It's if you start to act erratic. You have to remember, have you guys taken mental health yet? You have to forgive me because I don't remember. Okay. So no, absolutely not, Alma. Um, think about it. What do a lot of our schizophrenic and our bipolar patients do? They use illicit drugs, that a lot of them use alcohol, right, as a way of coping with the disease, right? Because a lot of them don't like taking the medications because they don't like the way the medications make them feel. Okay. So that is where your mental health could potentially become an issue. Does that make sense? I want to just be clarified. So no, if you're getting treatment for depression, but you're not a risk for yourself and you're not a risk for others, then there's absolutely no reason. A lot of people have anxiety, like mental health, where I'm talking about like mental health disorders that are going to potentially cause harm to your patients or risk for your patients. And I'm gonna stop sharing for a second, but I was going to tell you, I was reading something. So I do way too much reading. But I was, I, where I was listening to a podcast. I was not reading. Um, a lot of states have legalized marijuana, right? So you can, legally use marijuana. Be very careful. Um, because even though it is legal in your state, and I know some facilities will test for marijuana, others will not, but more and more facilities are now starting to test for marijuana. And if you are caught using, then and that includes, this is why it stuck with me, but it included those that had the medical marijuana cards. So yeah, so my daughter's an occupational health nurse, which I'm like, hey, got a question for you. And so like where she works, their policy is they can't use within 6 hours of their shift. So usually by then, the levels are low enough, they aren't really getting effect of it anymore. So that if they were to do a drug test, yes, it may still pop positive, but the levels will be a lot lower, right, than if I just used right before going to work. So just as a general note, be very careful and make sure you know the policy and procedures because I thought that was very interesting. And we always say, you can't use and go to work anyway, right? You can't, you smoke marijuana, you use a gummy, whatever it is that, before you go to work because you're going to put your clients at risk. That is a safety risk for your clients. But I thought it was interesting that even with the medical marijuana card, that they could potentially say no to employment with that. So I just thought, I'm like, how does that work? But again, didn't do any more research into it. I just thought that was very interesting. Um, so let's take a break before we keep going. Meet back at 2:50, or I'm sorry, 3:15. All right. So I will share my screen again. All right. So some of the disciplinary action related to the board and unprofessional conduct. So some of the things that they could do a fine or a civil penalty. They can also do a referral to an alternative to discipline program for practice monitoring as well as recovery support. They could do public reprimands, censure for minor violations with no restrictions on the license. They can do, they can impose requirements for monitoring, remediation, education, or other provisions. They can limit or restrict one or more aspects of practice. So probation, with certain restrictions, limiting their role, their setting, their activities, their hours worked. Or they can do separation, which would be a suspension, or they can do a loss of licensure, which would be either revocation, or in some cases, nurses will voluntarily surrender their license. Remediation, so that could be educational or exercises. And depending on the state, there may be some other ones. So I was sharing, I think in the review, one of the nurses that I worked with at a previous facility years ago, had forged a doctor's note. And the facility found out that it was a forged document and reported them to the board of nursing. And so they had to do some remediation. Not sure why he chose to do that or why they chose to do that, but so discipline steps. So what happens? So let's say a nurse is reported for stealing a client's narcotics to the State Board of Nursing. After receiving the complaint and determining that a chemical has affected the nurse's judgment, rendering them unsafe to practice, and confirming that the stolen narcotics are a violation of the Nurse Practice Act and the law, the board will review the complaint. Okay. Then the board will investigate, including questioning witnesses, gathering evidence. And then once they have, first they have to determine that it is a violation of the Nurse Practice Act or the law. They'll do their investigation and then they will bring it to a board proceeding. And that is where the nurse will have the opportunity to respond to the allegations against them. And then after the board proceeding, that is where they will determine the disciplinary action. So there's different varieties of actions that can occur. And then reporting and enforcing. So reporting and enforcement. So there's a database that's called NurseSys. It is a national database that is there to verify licenses, any discipline, any action privileges for nurses. So this site contains the nurse's license number, their date of license expiration, and any violations against the nurse. Again, this is a national database. There's also the National Practitioner Database. So federal law requires that adverse actions taken against a healthcare professional's license is reported to the National Practitioner Databank. And then there's always your State Board of Nursing online verification. So your nursing license is a matter of public record, so anybody can verify your license. So you can go to your State Board of Nursing, and that provides the public information about nurses have current licensure. And so it also allows for employers to confirm your license number, your expiration date, and if there is any board action that has occurred against your license. So other things to consider when we look at that, working in other states, I told you about the nurse compact states. So States have arrangements for interstate endorsements for nurses who choose to work in other states. Okay, so there's it really kind of so there's different opportunities. Like I was saying earlier with the multi-state license, if you live in Florida and you're closer to Georgia or you're closer to Alabama and that's where you want to work, okay, that is, if they're multi-state licenses, then you can cross those borders as long as you understand your Nurse Practice Act in each state. Otherwise, if let's say you are living in Ohio and you want to move to Alaska, okay, and you're going to be in Alaska for a while, okay, you want to transfer your license because that is going to be your new state of record. It's not like you have to go take another NCLEX, okay? What you would do is you'd go to that state board of nursing website and you would see what the requirements for licensure are, okay? Regardless, I will tell you at a minimum, you're going to have to do fingerprinting and background checking, all right? But they may have some educational requirements that you need to fulfill. So, for example, when I moved to Texas, to transfer my license to Texas, I had to take a jurisprudence exam. All right. I know some people that in order to go to New York, you have to do some child abuse modules. Okay. So it really kind of depends. Down here, the jurisprudence and human trafficking is very important. So you have to do continuing education specifically on those, in addition to others, but those are two really big ones down here. So again, that's why I said it's really important for you to know your Nurse Practice Act as well as the state that you're going to, provide care. And we've mentioned standard of care numerous times, but the nursing standard of care is your guideline for good nursing care. Okay. So, everybody's heard the phrase, you are held to the nursing standard of care, and that does have legal implications as well. And standard of care is based on what an ordinary, prudent nurse with similar education and experience would do in similar circumstances. With that being said, the Nurse Practice Act, your NCLEX that you're going to take, then your nursing program, your policy and procedures of your organization, laws, they are all resources to identify what the nursing standard of care is. Okay, so the Nurse Practice Act, it identifies the minimum level of competency for you to function as an LPN. The NCLEX tests for minimum competence. And again, like you said, your nursing programs, these are based on guidelines from the Board of Nursing. That's how we set up our programs. So just that's why I always say really important. Other areas that you can look at, NAPNES is one. The NLAPN is another one. All will outline the standards of care for your profession. How does the law affect us? So we look at it, we have criminal law and we have civil law. All right. So a criminal law is government versus individual. So it's these are things like your misdemeanors, your felonies, homicide, larceny, embezzlement, are all considered criminal. Your civil are individual versus individual. So there's some sort of an infringement on an individual's rights. And so the variety of things can, be a part of civil, but it usually will result in monetary compensation. So if somebody gets hurt, injured, right, the monetary compensation is, for their pain, their suffering, their loss of wages, all of those wonderful things. And that includes our intentional torts and our unintentional torts. So intentional torts are intended to cause harm. Okay, so it's either a threat or it's an actual physical harm, whereas an unintentional tort is you didn't mean to harm the clients. So if and like an example of an unintentional tort is giving the patient the wrong medication. All right. So you didn't follow the rights of medication administration. You gave the client the wrong medication and that caused them harm. Okay. It wasn't didn't do it on purpose. Okay, so that would be the difference. Intentional, you physically meant to harm that person. Other types of intentional towards assault and battery. Okay, so difference between assault and battery. Assault is the threat, battery is the actual beating. I hate to say it like that, but that's how I remember it. Okay, so assault is I'm threatening you, I'm gonna put you in restraints, I'm going to beat you up, okay? That's assault, but battery is the actual harm, okay? That is the physical harm to someone. False imprisonment and the use of restraints. Okay, so false imprisonment is keeping someone detained against their will. All right, so you have a patient that says, I'm leaving, I don't want to be here anymore, and you try to prevent them from leaving. Okay, so have them sign an AMA and you let them leave. You don't try to hold them against their will. And what else could restraints? Restraints can be either physical or they can be chemical. So you have a client that is up all night, wandering around, not really bothering anybody, but you're like, I'm just going to give him a sleeping pill so he'll go to sleep. That would be considered a physical, a chemical restraint, right? Can't use it for that reason. Defamation is damage to someone's reputation through false communication, okay, or even communication without their permission. And it's either can be done in writing or it can be done verbally. So writing is called, written defamation is libel, verbal defamation is slander. And then, of course, we have abuse. Physical abuse is always easier to identify than emotional abuse, but they both can occur and it can leave lasting marks on that individual. Unintentional torts on the other end. This would include negligence, malpractice. So negligence is, right, failure to use care as a reasonably prudent and careful person would use under similar circumstances. And malpractice is what we call professional negligence, right? That's just means it's negligence that occurs by a professional. And so common sources of negligence or malpractice, I'm sorry, medication errors, working while you're impaired, not following standards of care, failure to use a medical device correctly or equipment correctly. There was a case where a CNA was using a Hoyer lift by herself and dropped the patient, and the patient died. Actually had a patient who, similar situation, they didn't die. They were at a facility, the CNA, they were transferring him using the Hoyer lift and they dropped him to the floor. And he broke a hip in the process. So that could be, obviously, that could be malpractice or negligence. What else? Not acting as a advocate, not getting informed consent. Or if we talk about, delegation later on in this course, if don't if you delegate inappropriately, or you don't follow up on that delegation and it doesn't have the best outcome, you can be held responsible for that. Oh, I already said all that. Okay. Malpractice insurance for nurses. So unfortunately, more nurses are being named in lawsuits, okay? And we are liable for our own acts. And so why should you have malpractice insurance? For one, okay, the jury's award could exceed the limits of your agency's coverage. So, yes, your maybe the job that you work in is like, oh yeah, we have what do you call it? We have coverage for you, right? And so, but maybe they only have, $50,000 in coverage for you. Well, and the jury awards $100,000. Where do you think that other $50,000 is going to come from? Who's got to pay that other $50,000? you're going to have to pay that other $50,000. Or your agency that you work for may pay out an award because of because of that malpractice suit, and then turn around and sue you to recover the amounts that they paid out. So just, this is something to really, really, really think about. Or if you acted outside the scope of employment and then the agency argues that it's not liable, um, and your employer, again, it only covers you on the job. Or an agency might carry a policy that covers you only while you are employed at that institution. So let's say this thing, you got to remember, I don't know if anybody's ever heard the term statute of limitations. You have heard the term statute of limitations. So that's basically if something happens, you have a period of time. It may not be immediate that you have to prove damages to sue somebody. So let's say you're working at hospital A and something happens, and then you leave hospital A and you go to hospital B, and you're working at hospital B and something comes up from hospital A. And that you're brought in, a lawsuit is brought against you. Well, that hospital A may not cover you anymore because you don't work for them anymore. And hospital B isn't going to cover you, right? Because it didn't happen at that facility either. So there's lots of reasons why you should have your own malpractice insurance as well. Um, and like other things like, the agency may settle out of court and then they may come after the nurse as an individual. Or what if, your employer forgets to pay the malpractice premium? So there's lots of reasons why. I will tell you that your professional organizations do offer malpractice insurance. It is also generally a little bit cheaper as a student than it would be, and then it will be once you graduate and you are actually practicing, but it's always a good idea. We are a very litigious society, and I'm sure everybody knows that we are very litigious. And so, you work really, 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 really hard to get that nursing license. And you also want to make sure that you protect your license, to the best of your ability. And so this is just an added protection for you. And the hope is, the goal is, right, that you never have to be in a position. It's just like your car insurance, right? You have to have car insurance, but you also pray you never have to use it, right? And so it's kind of the same thing. You just want to make sure that you're covered in the event that something happens. So to prove negligence, all right? So, they can't always just, be like, well, she did this and this is what happened to me and I want money now. Okay. They have to be able to prove negligence, okay? And the four elements that are needed to prove negligence are going to be duty, breach of duty, damages, and proximate cause. Okay, so those all have to be present to cause an action for negligence against the nurse. So, duty means or refers to the nurse's responsibility to provide care in an acceptable way. All right, so the nurse had a duty based on education as well as the policy and standards of the place of employment. So you were responsible, right, for the patient's care. You were there, you had a duty to provide care for that patient. Breach of duty means that you didn't adhere to the nursing standard of care. What was expected of the nurse was not done, which is what we call an act of omission, or was not done correctly, which we call an act of commission. All right. So what is that? So an act of omission, you didn't give, I think I'm trying to think of the example I used earlier. All right. You didn't give the patient their their, let's say you didn't give the patient their warfarin or their Coumadin, okay? And the patient had a blood clot, okay? Developed a blood clot. So could they correlate? And then from the blood clot, they had a stroke. Okay. That was an act of omission. You did not give that medication. An act of commission. All right. Maybe you gave them the wrong medication. Okay. And as a result of giving them the wrong medication, they had an adverse reaction. And something occurred. So again, an act of omission means you didn't do something. An act of commission means you did something, but you didn't do it correctly. An expert witness is going to establish the standard of care. So then damages. Damages mean that the client must, so this is on the client, this isn't on the nurse. The damages mean that the client must be able to show that the nurse's negligent act injured him or her in some way. Okay, the client has to prove damages. So again, you didn't give them the warfarin, they developed the blood clot, they had a stroke. Is that directly related to the fact that you didn't give them the Coumadin? And that's what proximate cause is. So proximate cause means that there's a reasonable cause and effect relationship between the act of omission or the act of commission of the nurse and the harm to the client. So basically, did the nurse's negligent act cause the injury in question? So remember, this is on the client to prove this. And so again, duty, you had a responsibility to the client. Breach of duty means that something wasn't done or not done correctly. Damages means that the client has to has to show that the nurse's negligent act injured them. And proximate cause means that there is a reasonable cause and effect relationship, okay, that proved harm. So let me explain that one. So we do know, right? If I don't give somebody a blood thinner, then it is very possible, right, that they could develop a clot and they potentially could have a stroke, right? But let's say, I'm trying to think of something that would not cause harm. Let's say I didn't give them their multivitamin that day and they had a stroke or had developed a blood clot and had a stroke. Totally unrelated, but just saying, right? We know that not taking that multivitamin is not what led to that stroke, right? They're going to have to do a really strong correlation between that multivitamin, right, and them having that stroke. So that's what reasonable cause and effect is. Okay, it has to be a reasonable cause and effect. It can't be out in the universe just like, oh, we correlate it somehow. So if I'm going to bring a lawsuit, okay, obviously the first thing that the patient's going to do is call a lawyer. And we all know there's ambulance chasers all over the place, right? You see them on the billboards, you see them on TV. So the client believes that the nurse has violated their rights. They deviated from the, standard of care. So they're going to go see an attorney. The attorney, once they get all the medical records and all that stuff, is going to have an expert nurse review the charts. Okay. So before it goes anywhere else, okay, they are going to bring a nurse expert in to review the charts to see if there was a violation in standard of care. If there was a violation in standard of care or a deviation in standard of care, that is when a lawsuit is filed. If there is no deviation or from the standard of care, then guess what? That lawsuit isn't going to go anywhere. So that nurse expert witness is a vital part of this. Is the nurse expert an actual nurse? That's a great question. Yes, absolutely. The nurse experts are absolutely nurses. There is, and I don't know all the requirements for it, but there are legal nurse consultants. They are nurses who have, obviously they have to have some experience, right? Um, and they take, extra education to become a legal nurse consultant. I don't know if it's, I don't think it's a degree, but I think it's a certification that they get, but they do extra training and they are absolutely nurses. So after the nurse expert reviews the chart, then the complaint is filed and the defendant now can respond. And then they have the discovery period. This is like your pretrial stuff. Well, they'll do like the depositions, discovery. They'll do like more interviews, get more statements. They'll also like pull policy and procedures, those kinds of things. And then they'll do the trial. And so during the trial, right, this is where all of that information is presented to either a judge by themselves or if you have a jury trial, and then a verdict is rendered. Okay. And so again, the plaintiff, has the burden of proof. Okay. They have to be able to prove that your action is what actually caused them harm. And generally speaking, in these, it's usually a monetary compensation, right? For the most part, not always. Um, so it really just depends. And then if you don't like the outcome of the trial, there is also, the ability to appeal or request for another trial. If either the plaintiff or the defendant is not happy with the outcome of the trial, there's always a request for an appeal. All right. So, knowledge question. So, the nurse is caring for a client, miscalculated the dose of medication and administered it to the client, who was successfully resuscitated. Is this an intentional or unintentional tort? So is it so the nurse miscalculated the dose of medication? So is that intentional or unintentional?
Intentional.
Unintentional?
Unintentional,
Unintentional.
right? She didn't do it on purpose, right? Wasn't like, oh, I'm going to give the patient the wrong medication. No, I miscalculated and I gave the wrong. However, okay, it's unintentional, but is it negligence?
Yes.
Yes.
Very good. Yes. So the nurse has committed an unintentional tort in which harm was not intended, but the nurse did not maintain standard of nursing care and did not do what a prudent nurse would do, right? Always double check, right? Always double check those calculations. All right. Privacy and confidentiality. We've, I mean, I swear, like HIPAA, everything is HIPAA, right? We always have to make sure that we are providing for our patients' privacy. So, privacy means the right to be left alone, free from intrusion, as well as the right to choose care based on their beliefs, their feelings, their attitudes, and all of that wonderful things. It's also the right to control when and how sensitive information is shared. Okay. So we know that we don't disclose confidential information unless we have like a written, release of information to specific parties. There are some laws that require that certain client information be reported without the client's consent. Okay. So in order to report certain things, you do not have to have client consent. The purpose here is to protect the public. It's basically that's plain and simple. So some of the things that can be reported, communicable diseases. So oh my gosh, why can't I say this word? Communicable diseases, either to the local health department or the Centers for Disease Control and Prevention. This includes AIDS, okay? Try now, I will tell you the list is exhaustive. So if you are curious about what needs to be reported to the health department, you can go to your local health department and it will tell you what needs to be reported. So when I worked in peds, I think really the only thing we had two. I had a case of the mumps that I had to report, and then I had a case of salmonella that had to be reported because salmonella is reportable or it was reportable where I was. I haven't looked here to see what's reportable. Vaccine related adverse reactions. Okay, so if a child, an adult comes in and has an adverse reaction to a or comes in, you give a vaccine and they have an adverse reaction, that is reportable to the Department of Health and Human Services. So DHHS, oh my gosh, DHHS. And so reporting of some reactions is mandatory, for others it's voluntary. But you know, it adverse reactions are related. There's also another site, um, and I can't remember what it is off the top of my head, that you can also report vaccine related issues to. Criminal acts. So all states mandate reporting of rape cases. Okay, so some also may mandate gunshots, wounds, or even what do you call it? Sharp injuries. Some states also require reporting of blood alcohol levels that are above the legal limit. So again, you have to look at what your state mandates are. Um, what else? Equipment I'm going to put on here. Equipment related injuries. So when use of a medical device results in injury or death, it is reported immediately. Of course, you're going to provide care for that client, and then of course it will be reported. Clear and present danger. Okay, so HIPAA laws mandate reporting of client mistreatment or professional misconduct. So again, if there is any, misconduct, then that needs to be reported as well. Any abuse and neglect of a client, child, or elderly. So no, it sounds kind of different. So a child and the elderly, we are mandatory reporters for abuse. Okay. With adults of sound mind, it's a little bit different. And how do I explain this a little bit different? Okay. So if let's say I have an adult female come in and they are being physically abused by their spouse, okay, and they don't have a plan, they're just there to get their injuries treated. Um, we may not, they may not even tell you that they've been abused, you can just suspect it. What happens if we report that abuse about that woman? What happens if we report that abuse and start calling the police and other things? What could potentially
It
happen?
could potentially escalate the violence even worse because the abuser could find out about it and do something even more harmful.
Right? They're not ready to leave. If they're not ready to go, it could increase the violence at home. Okay. So what can we do? We can subtly give them information, right? Give them, a hotline to call, things like that. But that's why we specify with adults and with children and the elderly, because generally speaking, well, we know children can't advocate for themselves, right? They can't make that decision. And in a lot of cases, the elderly can't as well. So depending on where you are, you're either going to report it to your supervisor or your director of nursing, depending on where you are, and they will follow up and report. In a lot of your long-term care facilities, they will have an abuse coordinator. The abuse coordinator is usually either going to be the administrator or it's going to be the director of nursing that you will absolutely report that issue to. So with that being said, with certain things, facilities only have a limited number of, they have a limited amount of time in order to report certain things to Department of Health and Human Services. Okay. And so as soon as you recognize that something is happening, something is occurring, then you absolutely need to let somebody else know. Do not keep that to yourself ever. Um, Incompetence would be another one. Um, so, if, there is, alcohol, drug impairment, unprofessional acts that are taking place by a member of the healthcare team, whether it's a coworker, a subordinate, a supervisor, then that also needs to be reported as well. And of course, if there's a violation of the Nurse Practice Act, then, it will also be reported to the State Board of Nursing. We talked about client rights a little bit at the beginning, and anywhere you go, I mean, whether it's a nursing home, whether it's a long-term, I mean, a hospital or a clinic, everybody I'm sure has seen it. Even pediatric hospitals, there's a pediatric Bill of Rights, okay? And it's written in, a little bit, um, at a lower reading level, a little bit more understanding for, understandable for pediatric patients. It's also placed a little bit lower, right? So that they can see it. But clients, it rights are, we have rights under the Constitution, we have rights under state laws, we have rights under federal laws, and we have rights when we seek health care. So there's been lots of revisions about, over the, when we look at, clients' rights, but just some of the individual rights that clients have high quality care. So, and there has been a big push, and it's been a while since this started, but there has been a big push for quality versus quantity of care. Okay. So organizations, payers, Medicare, Medicaid, those kinds of things, they are looking at the quality of the care that is being provided, not the quantity of care, right? So you have a patient that comes in and, they, um, were, otherwise, let's say you had a patient came in, they were having symptoms of a heart attack, and they had a heart attack and you have them in your care and, they develop a pressure area. That's not quality care, right? Because we didn't do something along the way. We didn't do the turn and repositioning. Maybe we didn't, um, provide good, nutrition, whatever it is, right? That's not quantity. That's not quality care. So high quality care, a clean and safe environment. Oh my gosh. Every time I think of clean and safe environments, I'm going to tell you a story, and this bugs me to this day. My grandson, he is going to be, well, he's going to be 2 in May. All right. And so when my daughter was getting ready to, she had to be they had to do an early induction because she had cholestasis. So they did an induction. Anyway, long story short, so we get to the hospital, right? And she's getting all set up. And my son-in-law, I don't know what he was doing. Oh, they have those little couches for the dads that the dads can sleep on, with so they can stay with their partners. Well, he pulled it out for some reason because he dropped his pillow had fallen behind the couch. And when he pulled it out, there was like somebody's clothes back there and like candy wrappers and I'm thinking to myself, like, this is gross, right? Who cleaned this room the last time? Um, I just think of I am not a germaphobe. I am not a germaphobe by any means, but I am one of those nurses. When I get to work, I wipe off my med cart, my computer, the keyboard, the mouse, I got the purple wipes going everywhere. I'm also making sure that my patients' rooms are clean. I hate walking into a room to give somebody medications and there's like 15 half full cups of water on their bedside table. Why? just take it with you. If they don't drink the water, take it with you, dump it out, throw the cup away. Like it drives me nuts. So yes, I'm that nurse. Um, but it's just, I don't know. Yeah, I'm sorry, home health. I can't do home health. Alma, I don't know. I can't do home health. I guess I'm not a perfectionist. My house is not spotless. It is not cluttered, okay, but um I can't go into other people's houses. Like I just can't. I don't um yeah, I've known too many hoarders in my life. Like um yeah, I can't do it. Can't do home health. Um but safe as well. And that's, making sure if you spill water on the floor that you clean it up. That another thing too, and this drives me nuts, is people, a lot of the bathrooms, in the rooms, they have showers in them. And they'll leave their towels and things on the floor, pick it up, right? That's just a trip hazard for them. Making sure that we're keeping them free from infection and, other potential issues, keeping them involved in their care. Absolutely 100%, right? They are the center of our nursing process. So making sure that they know what's going on. Like we were saying, like I said earlier, right? It's overwhelming going into a healthcare facility. You got people coming in all the time, wanting to poke and prod and ask you questions and give you medications and do all that. And they're like, well, what's going on? Why do all these people keep coming in? Protect their privacy, always. Help with when leaving the hospital. This is a big one too. Think of someone who's had maybe a major trauma, a heart attack, a stroke, or newly diagnosed diabetic. We're going to give them as much education, as many resources they can while they're in the hospital. But what happens when they leave? Right? They're kind of just thrown to the wolves. And I hate to say it like that, but making sure that they have help when they leave the hospital, even if it's setting up their follow-up appointment with them so they know when they go back to the doctor, making sure that they get their DME, that they know about their medications, who can they call back to if they have questions. It's a big one, right? You get sick, you had a trauma, you're leaving the hospital. The nurse is throwing all this information about your discharge paperwork, and here's this, and here's that, and this is your medications, and this is that. Well, what happens if you don't understand that? Or you forget something, even though you have it, usually we'll have written instructions as well. Okay, who do I call if I don't know the answer or I need an answer to something, right? That should be a big part too. And of course, help with billing claims. Um, It's insane how expensive things are. Like absolutely insane how expensive healthcare is, right? How do we work around that? If they have I've been on the receiving end of this. This was a long time ago, like long, long time ago. Um, I was double billed. And I kept trying to explain, like I'm getting two different bills from, one from the hospital and then one like from something else. And it wasn't supposed to be like that. It was supposed to all be combined, but both of them wanted their money. And I was trying to get clarification. Not that I wasn't trying to pay. I get it. I have to pay my healthcare bills, but like they had some kind of disconnect with their billing department and I was getting double billed and nobody wanted to listen to me, right? And that can be frustrating too, right? You're like, you're not listening to what I'm saying. So when we look at that, right, we really need to make sure. And there's people in hospitals that can help with that. And it's as simple sometimes when they're being discharged to say, hey, this is who you call if you need this. This is who you call when you need that. This way they know, you know, just like, you know, when to seek, hold on one second, when to come back, right? Like, you just had a surgery, we give you all that information. If you have a fever, excessive bleeding, like all these things, right? This is when you come back, right? They need to know if you have these symptoms, right? When to go back and seek help. So it's about, and this is really, what does this all sound like? Sounds like patient advocacy, right? Making sure that we are doing the best thing for our patients. All right, I'll give you guys another break. And then we will finish up. So be back at 4:10. All right. Excuse me. All right. So let's finish up. Share my screen again. All right, so let's talk about some HIPAA. So HIPAA is the Health Insurance Portability and Accountability Act. Took place, where in, I think, early 2000s, I think is when it initially was put in or went into effect. I remember I was a nurse at the time, and it was a learning curve for a lot of us, not knowing what we could say, what we couldn't say, all of that wonderful stuff. But the original intent of HIPAA was, portability of insurance for employees from one job to the next. However, of course, one of the main focus of HIPAA is always client privacy. And so everything's been, it's updated quite often, just to make sure that we all stay in compliance. So when coordinating care, the nurse needs to adhere to the minimum necessary rule to protect the client's privacy. So client's name, address, payer information are appropriate for the nurse to disclose to a vendor. So what that means is, let's say we were talking about help while leaving the hospital, right? So if the client needs to, let's say we need to order DME. So maybe the client needs a hospital bed, elevated commode, a bed or a bedside commode, or a walker, a wheelchair, whatever it is. When we, call to order that equipment, so you call the DME company up on the phone and you're like, okay, this person's discharging from the hospital. They need this, this, and this. You can give them the client's name, you can give them the client's information or the address, and you can give them their insurance information. Okay. Um, a lot of times too, right? You're gonna have to fax over orders, things like that, or make sure the client has an order. So when they deliver it, they have them. But at the bare minimum, yes, absolutely. You can give them their name, give them their address, give them their insurance information so that they know who to contact, right? Who to bill for those services. All of the all covered entities within HIPAA are required to have a privacy officer. Okay, so you go to the doctor's office the first time that this year, okay, what's one of the first things that they're going to do? They're going to tell you, we've updated our privacy policy or our privacy practice, and you have to sign it. And they always ask you, do you want a copy of it? And that's completely up to you. But one of the provisions in there is that they have a designated privacy officer. So, with that being said, if you think that your privacy has been violated, leaked out, whatever it is, okay, you have to, you need to be provided with that privacy officer's name so you can call and file a complaint if you feel that your privacy has been violated. And that is one of the provisions in HIPAA. I don't know if anybody has ever read any of the HIPAA privacy things that they signed. Um, but that information is in there. Okay. So they, if, or even if you're working and, a client tells you, hey, um, I think that my privacy has been violated or somebody has been given my information, whatever it is, you give them that information for that privacy officer. And they can discuss it with that. And then, of course, the privacy officer is going to do an investigation and, and to see what happened if there was a violation. Um, we'll hit client competency. So we look at client competency. It has both a legal meaning as well as a clinical meaning. So some clients' rights are based on proof of competence or incompetence within the legal system. Okay. So legal competence, okay, is a client who is 18 years or older. A pregnant or married woman is legally competent, even if they are under the age of 18. A self-supporting minor, or we used to call them legally emancipated minors. So they have gone to the court to become legally emancipated from their parents, or competence in the eyes of the law. Okay, so most of us are considered competent, right? Incompetence is determined by the court. Okay, so think of incompetence. So like your dementia patients, right, might be considered incompetent or deemed incompetent, certain mental health conditions, other things, right? They go to court, they are deemed incompetent, they usually are then assigned a caregiver, right? Just put my jacket on the floor. Clinical competency, just trying to grab my jacket, is someone who can understand the problem, why they're going to the healthcare provider. You know, like I have a sore throat, my foot hurts, my shoulder hurts, I have a headache, right? They can identify why they're going and understand the problem. They can understand the options for care and the possible consequences and make a decision based on sound reason. Okay. So, whatever the whatever the reason they're seeking healthcare, right? They can make the decisions regarding their care. So when we look at consent, implied consent is treatment that is obtained on admission. Okay, so this is what I was saying earlier, right? You go to the doctor's office, you go to the emergency room, you sign a piece of paper that says, yes, I'm here. I agree to allow you to treat me, right? And so usually it's, whoever's working the front desk or the intake in the emergency room. And so they are seeking, assistance. They're going to sign the consent. Anybody can withdraw consent at any time, right? You have the ability to leave. You can write against medical advice. You can say, I'm just going home, whatever it is. Informed consent is a little bit different. Informed consent must be obtained for invasive procedures, okay, whether it's therapeutic, whether it's diagnostic. But basically, informed consent is all the good, the bad, and the ugly, right? It's what what the diagnosis is, or if they don't know, maybe they have to do a biopsy or they have to do a procedure in order to determine the diagnosis, right? So the diagnosis, the suspected diagnosis, the purpose and the description of the treatment. Okay. So what are we going to have done? And I'm going to use myself as an example here. So a few years ago, I had early onset, cataracts. Okay. I didn't take care of my eyes very well when I was younger. And I had to have cataract surgery. And so rather than the doctor sitting here and having this, long discussion with me about the cataract procedure, he sent me, he literally had me watch a couple videos. One was, all about cataracts and da da da. And then the other one was all about the procedure. And literally, it was somebody having a cataract procedure, and it walked you through the whole procedure from when you got there until after you went home. So that is something that some providers will do. They will have them watch a video, give them a website information, YouTube, whatever it is, and then have them sign the consent. Also need to know what the expected outcome, benefits, side effects, complications that can occur as a result. They'll also any alternative treatments, okay, as well as their benefits, side effects, complications that can occur. So if you don't want to do this surgery, maybe we can do this procedure instead, okay? And this is what this is. The names and qualifications of the people who will perform the procedure. All right, that's really important. If I'm going in for surgery, I want to know who's performing my surgery, okay? So, you obviously, for most people, unless it's a trauma, you've met your surgeon before, okay? You've had a visit with them, so you know them, all right? But a lot of times when you go into a surgery, there's other people in there. There may be, he may have a physician assistant, he may have a resident in there doing this, helping with the surgery. You have the right to know who is in there. and the names and what their qualifications are. Now, the internet has really helped that, right? You can go Google now and see, the good, the bad, and the ugly about your provider. The prognosis if the treatment is not done, if it's known, okay? A lot of times, we don't always know what the outcome is going to be, but this is what could potentially happen. Answers to any questions that the client wants clarified. They don't want to understand something, then the provider needs to stay there until at least they understand what, and have answers to their questions. And then they also need to know, just like I said earlier, they have the right to withdraw consent at any time. Okay. You could be wheeling yourself into the OR and you're like, stop. I don't want to do this. Okay. So you can withdraw written permission at any time. Authorized consent. So parents cannot give informed consent for their kids, okay, but they authorize treatment for kids and until 18. And that is what we call authorized consent. Okay. So, we as parents, we usually know what's best for our kids, and we're the ones that provide consent for whatever treatments, procedures that the kids need to know. Okay. But that is, we give authorized consent. We do not necessarily give informed consent for our kids. Now, we know minors mostly under the age of 18. However, some states also allow minors to give their own consent for things like substance abuse, pregnancy, not pregnancy, sorry. Oh my gosh, substance abuse, mental health, sexually transmitted infections, and so they can give their own consent for things like that. Then talked about that. All right. Then we look at end of life issues. So the Patient Self-Determination Act, it requires that Medicare and Medicaid providers give adult individuals, when they are admitted, certain information about their rights regarding advanced directives. And so if you've ever been in any kind of healthcare, they'll ask you, do you have any living will or advanced directives? And if you do not, they'll ask if you want information regarding a living will and advanced directives. So advanced directive, living will, start with living will. A living will is an advanced directive. It's a legal document. It just describes what kind of medical treatments, life-sustaining treatments that you would want if you were seriously or terminally ill. Okay. And, you do this usually while you're younger, while you're still in sound mind. But, knock on wood, something happens. Do you want blood products? Do you want a tube feeding? Do you want to be trached? Do you want to donate your organs? Do you want dialysis? Hydration, pain medication, whatever it is. Okay. It is not used to specify who's going to make healthcare decisions for you. You are making these healthcare decisions. This is your living will. Okay. It can, so that is your express conditions. The other hand of this, we have a durable medical power of attorney. Okay. This is a legal document. It is valid in all 50 states. And this is where you name a healthcare proxy. Okay. So this has to be somebody over the age of 18 that you trust wholeheartedly to make medical decisions for you if you no longer can make them for yourself. Okay. So knock on wood, there's a trauma, or, you start early dementia, or, whatever the case is, you are no longer able to make decisions for yourself, and you have assigned this medical power of attorney to make decisions for you. Okay. And again, it's legal, all 50 states. So that's probably one of the hardest things that people do, is trying to find somebody that they trust enough, right, to assign as a healthcare proxy. A DNR or a do not resuscitate order is an advanced directive. It is based on the Patient Self-Determination Act that gives the client or gives the healthcare provider, sorry, legal permission to write such an order. So the healthcare provider can also write a DNR for a client who no longer has decision-making ability, but does not have, any personal advance directives written and signed. Okay. But DNR. So let's say, you have a terminal illness, you've done all the treatments, there's nothing else that anybody can do. Or in some cases, in people that I know, if they die, they just want to die. They don't want any resuscitative, measures taken, whatever. It's completely an individualized choice. But this allows it is a formal document. It is a legal document. It goes in the patient's chart. If you're working in home health, like in hospice, it's usually going to be posted on their refrigerator somewhere that it is well seen. And it can be revoked just like anything else. Okay. Usually, once a DNR order is written, it stays in place unless it is revoked for whatever reason. Maybe they've decided they don't want to be a DNR anymore. It can absolutely be revoked. But the client has to sign that, has to make it known that they want to be a DNR. They have to sign the paper. The physician has to sign it. It has to be witnessed. And then the doctor can write the order for the DNR. And I know people that carry their DNR around with them so that they always have it with them just in case something happens. Like there was a couple years ago, I don't know if anybody else saw it, where people were writing DNR, like getting tattoos of DNR put on their chest. Did you guys hear about that? Anybody hear that? Like, there's people literally that'll have DNR like tattooed on their chest. That's not legal document, okay? Just because you put a tattoo on your chest does not make it a legal document. You actually have to have that legal document that says, I want to be a DNR. Then we have our Good Samaritan Act. So the Good Samaritan Act, it stipulates that a person who renders emergency care in good faith at the scene of an accident is immune from civil liability for his or her action while providing the care. And so you can, go to your individual state, and look at your state Good Samaritan Act. So I'm just going to leave like that. There's lots of controversy and lots of controversy about Good Samaritan Acts. And I'm sure other people have heard stories about, Good Samaritans trying to do the right thing and stuff happens. But it does protect, if you provide emergency care in good faith at the scene of an accident. And then the last part of this is we have euthanasia. Oops, didn't mean to go that far. So euthanasia, end of life care. I always think of, when I think of euthanasia, I always think of Dr. Kevorkian. I don't even know if anybody knows who Dr. Kevorkian is anymore. But when we look at physicians assisted suicide and euthanasia, they are absolutely different. Okay. They are not the same. So it is, we have what are called active and passive euthanasias. Okay. So active euthanasias are processes or actions that speed the process of dying. So this would be actively ending a person's life or initiating the dying process. It is morally wrong. It is legally not allowed, and it is forbidden by professional organizations. As a licensed nurse, you are not allowed to participate in euthanasia. And speaking of that, anybody see the series The Good Nurse? Crazy, right? Crazy, right? We are not allowed to participate in euthanasia. Absolutely not. It is against all of our profession. American Nurses Association, do not do it. Passive euthanasia is a little bit different, okay? We're not doing anything to preserve life, but we're not killing them at the same time, okay? So we are avoid prolonging a person's life, and they are just allowed to continue through the process that is going to cause death, okay? So we think of this is like our hospice care, right? It is morally permissible, it is legally allowed, and it is approved by professional organizations, okay? So the little disclaimer on the bottom of this. Doubling the dosage of pain medication without a prescription is illegal and can be construed as active euthanasia. Again, we do not practice active euthanasia. We do not purposely try to end a person's life. With hospice, we allow them to go through the dying process with dignity, right? Still providing care. Okay. We are just allowing them to go through that dying process. So, some important things to remember. Personal liability. Again, we're responsible for our own behavior. A student nurse is held accountable to the standards of an LPN. The most common type of negligence in practical vocational nursing relates to action or lack of action, not what was intended to be done. So again, this would be like the nurse who failed to report a critical lab value to the provider, which resulted in injury to the patient. The nurse's best defense for the prevention of legal liability is to develop a rapport with the client, right? You've heard about establishing those therapeutic relationships, right? Developing a rapport with your client is going to be your best defense. The LPN, LVN should also be clear with the RN if something is not within their scope of practice. So we know, like, for example, initiating client education, doing IV push medications. If it's not in your Nurse Practice Act, you cannot do it. And organ donation, I don't know why this wasn't, but organ donation is a voluntary act. You cannot be coerced into donating your organs. Okay. It is a voluntary act. When you go to, what is it, DMV, right? Isn't DMV the one that asks you about organ donation? I know I have it on my driver's license. Like, they can take whatever they want. I'm not going to use it anymore. But I want to go back to a little bit real quick more with euthanasia, active versus passive. So administering, okay, so let's say a lot of times, and I've seen this and I've seen other nurses kind of have this struggle, okay? So what happens, right, when you are working with a dying patient who is in a lot of pain, okay? And you have that morphine right there and then, but you're like, they're not breathing very well. Maybe their respirations are only like at a 9 or a 10, but they're still in a lot of pain. What do you do? Do you give them the pain medication, knowing that it could suppress their respiratory system even more, or do you let them suffer? That's a good question. What do we do? What do we do?
Maybe ask the doctor to,
Yeah, I was
what
gonna
else we
say
can
S
do.
bar.
SBAR. So if we have an actively dying patient that is in pain, and knowing that, the intent is just to alleviate suffering, you can give that morphine.
Give it to them.
Yep. You're not killing them, right? You are relieving suffering. Okay. It may hasten their death a little bit, right? Because it may, slow down their respirations. But would you rather them be suffering, knowing that they are in pain, right? And I will tell you, I've met nurses that they struggle with this. And I've struggled with it too. Like, I know they're in pain. I see them in pain, but I'm like, if I give them this pain medication, right, what's going to happen? And I've not ever had that happen. Like, I've never had given somebody pain medication and they died within like that, but the intent always there is to really alleviate the suffering. Um, and that is allowed. That is okay. That isn't something now if you went in and, gave them half a bottle of morphine, right? Like, I mean, a little bit different, but we're talking about acting as a prudent nurse, right? And what we would do. And it's in, like I said, that decision is rough. And I've been in that place and I'm like, oh, what do I do? Um, but you're not killing them, right? You're just helping to alleviate the symptoms, um, and trying to provide them some comfort. And that's the whole premise with behind hospice is death with dignity, right? Maintaining their dignity as they're going through that dying process and to be free from pain. One of the biggest fears for anybody, what in whether you're living or getting ready to die, is being in pain. Nobody wants to be in pain, right? I don't know about y'all, but I don't like to be in pain. And so, trying to provide that good pain relief. We have a couple more minutes, but does anybody have any questions?